Very less aware of the diabetes itself, the cause, the effect, the outcomes, the cost, and what happened, they just want to see the sugars normal, and beyond that they don't see, and everything practically they want to keep on the shoulder of the doctor, that it should be done by medicines or insulins or anything, and then they creep about the cost. But when I tell them the cheapest medicine for diabetes is exercise, diet and meditation, that they don't want to practice.
Eat less, isn't it?
Eat less, walk more or whatever. That is not practical. They say we don't have time, but they will go to watch a movie or whatever. And I have, if you can see outside in my OPD, I have kept the photo of me running marathon, full marathon. I am a full marathon. But then when it comes to teaching them, I tell them, खुद मरे बिना स्वर्ग नहीं जा सकता. If I run marathon, your sugar is not going to go down. So you have to cut down on your calories through your exercise. Otherwise, I will be better controlled, but you will never be.
Okay. And what kind of patients come to your clinic? Are they mostly type 1, type 2, or a mix of them?
No, mostly type 2.
Okay.
In India, it is 97%, 96%, 95%. Okay. It is type 2 all over in the world.
Okay.
But somehow incidence of type 1 seems to be increasing. Reasons are yet to be known, but yes, incidence is on the rise.
Okay. And in terms of the difference between type 1 and type 2, many of the diagnostic companies also say that they are two very different animals. You can't even compare the two. So in that term, in those terms, what do you feel are the requirements or the basic difference that you find among the patients?
See, as it is rightly said by you, type 1 and type 2 are entirely different, barring only one similarity, that is high sugar. Okay. Type 1 and type 2 differ in the cause and effect both. The cause of type 1 is where beta cells, which are the production site for insulin, that is completely destroyed. For example, see, this is pancreas.
Okay.
And these are the beta cells. Okay. In type 1, due to some infection or some factor and genetic predisposition, total beta cells are destroyed. So there is no insulin production in the body. But in type 2, there is a mixed pathology. First, there is a progressive loss of beta cells, and then also there is insulin resistance, that is obesity and related disorders, mental stress, everything so much. Whereas type 2 is a mix, where obesity, insulin resistance, genes, mental stress, diet, exercise, intercurrent infections, drugs, everything matters. And then there is partial loss of beta cell and slow progressive death of beta cells.
Okay.
This is type 2.
Now, doctor, what happens in essentially type 1 diabetes? When you talk about the insulin not being produced in the body at all, what do you think are the new ways of dealing with it? And are you really happy with the research that is happening in diabetes?
Yes, see, type 1, or which was earlier called insulin dependent diabetes or juvenile diabetes, which is no more use the term, it is type 1 where total insulin deficiency makes it mandatory for the person to take insulin to survive.
Correct.
Now insulin is available only in injectable form and not oral or intranasal form, which was tried. Research is going on, but till then we have to live with insulin, multiple injections in type 1 diabetes. But those who are very brittle diabetic, very fluctuant, for example, they go in hyperglycemia very fast, then we have come out with a novel therapy of insulin pump. Now insulin pump is the in thing, and there are various models available, but the cost is a constraining factor.
True.
But other than that, insulin pumps resemble pancreatic action in the body, and they are good to use, they are easy to use, people can maintain their lifestyle with good flexibility, they can swim, they can run, they can do so many things. But now latest thing is going on pancreatic transplant. Cadaveric transplant, because live transplant is not possible to do like in liver transplant. In liver transplant we can have some tissue of the liver removed and implanted on the patient, but In pancreas, it is only dead man's pancreas which can be used,
Okay.
and it is used with some success, and the life can be prolonged by 5 to 6 years maximum. But the trial is going on, and we hope to hit the bullseye maybe in coming era.
But doctor, why is that, we don't have a completely automated system of insulin pump? You still need manual intervention. People have to actually decide what the dose is and inject it themselves. That is not a completely automated.
No, see, I'll tell you, there are 2 or 3 types of machines available. Base model, moderate model, and a very high-end model.
Okay.
The highest end model has got facility what you are describing. It is a bit costly, but it has got inbuilt glucometer, okay, which takes the reading 288 readings per day.
Okay.
Okay, there is automatic calculator in that machine, and there is a auto cutoff. For example, patient goes in lower than 70 sugar, machine stops pushing insulin inside. But then, as you rightly said, exact mimicry is not possible.
Okay.
So that will take some time.
Okay.
But otherwise, more or less, physiological patterns are recognized, and they are picked up by these machines and followed on its own. Very rarely, when you are going to change your lifestyle, diet and something suddenly,
Okay.
you may need to adjust your basal or bolus dose. Otherwise, it's fairly reliable.
Okay. Doctor, also it is known that organ failure is quite inevitable for diabetics after about 20-22 years. Do you see the same kind of trend among your patients?
Well, my patients are also part of the general population upon which the studies are done, and yes, it becomes the same pattern with everybody. But at my level, when the patient comes into my hand, I tell them that, look, my first action is primary prevention, that is no diabetes in the person coming inside. Suppose you come with borderline sugar, I'll see to it that you become non-diabetic again. But if you become diabetic, then my first goal is to prevent complications as long as you survive.
Absolutely.
And if I follow the guidelines rigidly and patients cooperate with proper lifestyle modification, then we successfully do it. For example, patient stops smoking, patient takes up exercise, patient changes the job to a less stressful schedule, and meditation. All these things, when they are combined with proper pharmacotherapy,
Okay.
we can prevent complication, although not altogether, but at least we can delay the onset of complication.
Okay, now there has been so much of talk about stem cell therapy and how much that's going to help diabetics. What is your reading into that situation? Do you
Well,
think
stem cells therapy have done a good in lot of other fields, but in diabetes it has yet to produce results. Trials are on, but the results are not so very promising. So we are still skeptical and we are waiting for more data to come in. So I cannot comment too much on that, and I don't put too many hopes on that
you don't have to do that?
right now, as of now, because the data is not very clearly encouraging.
We have been meeting a few of the diabetologists as well as a few of the stem cells experts. And they say that, for instance, like Dr. Mahajan, I don't know if you are friends with him, from Thane at Bali. Now, there are several of them who say that the cure for diabetes is coming in about next 5 years' time. Would you also feel that?
See, I'll tell you, exactly 13 days back, I was in Chennai with Dr. V. Mohan's Academy of Diabetes, in which I have enrolled myself for a 2-year course of diploma in diabetology with Cardiff University.
Okay.
The discussion for the latest treatments were discussed, and in that stem cell therapy was discussed, and there Dr. Doyle, he said that very clearly that stem cells are not yet fully proven to be effective in diabetes management.
Absolutely.
Yeah.
Till now, it's
So
not
see,
been proven.
as of now, there are so many possibilities: pancreatic transplant, islet cell transplant, this immunotherapy or stem cell therapy, so many things. But they are all in a stage where we have to keep our fingers crossed and wait for the best outcomes, hoping to cure diabetes.
Okay, doctor. There is also a feeling among diabetics that if you control your blood sugar as well as your blood pressure, your lipid levels, basic levels, you can actually prevent all kinds of related disorders. Would you also say that your
That is the
patients-
crux of the management of diabetes. There were 2 trials done in the past. One was parent trial, DCCT, diabetes complication and control trial somewhere in US or UK, in which most of the studies were done with stringent control of sugar,
Okay.
but they ignored BP and cholesterol. And there were 2 sets of patients. One set where they had controlled sugar very tightly, and the other side where they had relaxed the sugar readings, but they had controlled the comorbidities in terms of hypertension, dyslipidemia, kidney management, etc. And after 20 years, they found that the group 1, which was very tightly controlled, had more mortality, more deaths and more complication compared to second group. So then we came to know that no, only sugar management is not good. You cannot be glucocentric. I mean, patient coming with normal sugar, doctor, I am normal. No. Inside you could be a time bomb. You may be harboring high LDL. Absolutely. You may be harboring high low HDL, high triglycerides, hypertension, microalbuminuria, all these things, retinopathy. If it is not screened, not looked for, you may miss the bus. So controlling sugar is not enough. Giving overall good quality of life to the patient is most important.
And what about the feeling that Indians are more predisposed to diabetics, especially on account of the genetical factors, especially the triple genes?
Not only Indians, it is the Southeast Asians, and we have 50 genotype and phenotype both. Dr. Yagnik at Pune has done a lot of research in that, and he has found that maternal malnutrition can lead to fetal development of insulin resistance, because when mother is not getting enough fuel, the fetus gets a signal, the child gets the signal that he has to conserve the energy for future. So the genes become that way, and that insulin resistance carries on in the adult life, and then they get obesity and catch-up growth later on to become diabetic.
So essentially it would mean that it's the prosperity that is leading to diabetes.
Maternal malnutrition.
Correct, sir.
I'm talking about malnutrition. These studies was done in interior of Maharashtra, and there they found that ladies had to travel kilometers and kilometers to fetch water, even in pregnancy. So what happened? They got less nutrient plus hard work.
Correct, sir.
So those children, they were born low body weight, but they tend to become obese in the catch-up stage.
Correct.
And then they become diabetic.
Completely agree.
So then now they have concentrated on giving good nutrition to those rural maternal part. And once you prevent maternal malnutrition, you are reducing the incidence of adult diabetes in India.
Correct. Correct. Completely agree on that. My point was that when those children who have thrifty genes, they get prosperous. They are more
naturally, because their genes are insulin resistant genes. They are towards conservation of energy rather than spending of energy. So in the end, their BMR is low, and they conserve the energy and put on weight.
Okay. Now, tell us about the problems related to eyes. How many of your patients actually get into eye problems?
Say around 7 to 10%.
Okay.
They do get eye retinopathy,
and
also premature cataracts. Cardiac problem as the age advances and with poor control. See, in my own patients, incidence of cardiac problem is very less, because I have been taking care of all the factors together. But patients coming in from other people, other places to manage, they are at times very lax, and then they'll end up with sudden cardiac development. In fact, I'll tell you one example. This morning, one lady, she approached me with chest pain, and she was bearing that chest pain for 7 days because it was not so much. And on taking ECG, it was inferior wall infarct, and she is diabetic only for 3 years. But she was not even on statin, not even medicine for hypertension, only sugar medicine, that's all. And then I told them that, look, this is the reason, you have time bomb inside. Only 3 years of diabetes. Imagine what must have happened. Her sugars were normal and an infarct. So if you don't control overall, yes, incidence of cardiac involvement is going to be high.
Okay, and what about nephropathy?
Nephropathy is say around 5%, around that many.
Okay.
But yeah.
Many of the doctors whom we also talk to, they say that most people don't lose their eyesight. It's the kidneys which are very susceptible to diabetes. Would you also agree to that?
Maybe kidneys are easy to screen through urine test and being picked up fast. Retinal scan, that is fundal photography, is not easily available to all patients. Whereas see, a patient walking into my clinic, I have got fundal photography machine. But not every diabetes clinic will have a fundal photography machine, or a physician's clinic will have a fundal photography machine. But I can collect urine and screen them for microalbuminuria immediately.
Correct.
So it's very easy to pick up kidney. Sonography is easy.
Correct. No, my doctor, my point was something else. More people tend to lose their kidneys than their eyesight in diabetes.
Overall incidence, yes. overall incidence,
Any
yes.
particular reason for that?
Not that I can think of directly. It is just that maybe natural selection of the organ failure. Some people come with retinopathy because both are microvascular complications. And in fact, when we see nephropathy, we tend to screen retina for retinopathy, and when we see retinopathy, we tend to screen the patient very detailed way for nephropathy. So more or less, both of them go hand in hand. Not always one is better than other, or rather one is more than other. But sometimes, yes, maybe if the incidence is showing that way, there must be some reason which I don't know.